This lecture we're going to cover Chapter 14, the elbow and forearm, as well as Chapter 15, over the wrist. So we'll start with the elbow and forearm, and the elbow and wrist both together allow the upper extremity to functionally lengthen and shorten so that we can do things with our upper extremity. Without those joints, we would just have this long rod that didn't do much for us. We wouldn't be able to get food to our mouth or drinks to our mouth or put contacts in if we're visually declined. The elbow complex is made up of two articulations. So we have the articulation of the trochlea of the humerus and the trochlear notch of the ulna. The trochlea of the humerus is convex and the trochlear notch of the ulna is concave. This is a synovial joint, meaning it has a joint capsule, synovial fluid, all of that fun stuff. It is a hinge joint and it is uniaxial. We also have the articulation of the humerus with the radius. So we have the articulation of the capitulum of the humerus with the head of the radius. The capitulum of the humerus is convex and the proximal surface of the radial head is concave. So both parts of our humerus are convex surfaces, and both articulations for our elbow, both the radius and the ulna, are concave. This too is a synovial joint, meaning it has a joint capsule, synovial fluid, synovial membrane, and a hinge joint, making it uniaxial. Then for the forearm, we have the proximal and distal articulations of the radius and the ulna. And we need to have both of these joints move for pronation and supination to occur. So the proximal articulation of the radial notch of the ulna and the head of the radius. The radial notch of the ulna is concave and the head of the radius is convex. It's a synovial joint and is uniaxial for pronation, supination. And the distal articulation of the ulna and radius is also a synovial joint. It's a pivot joint that's uniaxial, and so we see rotation happen as a result of movement of the radius on the ulna at both the proximal and distal radial ulnar joints. So we can see an image of the radial ulnar joint here where we have the proximal radial head articulating with the radial notch of the ulna, and then we have the distal radial ulnar joint where they articulate just above the wrist. Motions of the elbow and forearm are going to include our flexion and extension of the elbow and pronation, supination of the forearm. Our normal ranges of motion that we want to know for the elbow for flexion is going to be 0 to 140 degrees of elbow flexion. 0 is going to be our normal range of motion value for elbow extension. However, some people have a few degrees of hyperextension, and I think we saw that when we did our range of motion in Goni Lab in class. For supination, where the palms face anteriorly from anatomical position, we have 0 to 80 degrees, and pronation, we have 0 to 80 degrees. When you guys assess these on each other, you're probably going to find that you have greater restrictions into supination than you do pronation. When we talk about these ranges of motion, we also want to consider what is the end feel for each of those ranges of motion. So for elbow flexion, we should have a soft end feel. For elbow extension, we should have a hard end feel. And for pronation and supination, we should have firm end feels. Here is your visual demonstration of what elbow flexion is. So the hand comes closer to the shoulder for elbow flexion, and elbow extension is when the hand moves farther away from the shoulder. The closed pack position for the humeral-ulnar joint, or our elbow joint, is going to be full extension and supination, so that's where we have the greatest bony approximation. The loose pack position, where we have the greatest motion between the bones, is going to be 70 degrees of elbow flexion with 10 degrees of supination. We talked about flexion, we should have a soft end feel, and extension is a hard end feel. And if we're looking at the capsular pattern where we have range of motion restrictions as a result of something to do with the capsule, we lose flexion more than we lose extension, and we lose flexion first. For the proximal radial ulnar joint, the closed pack position is going to be 5 degrees of supination, and the open pack is going to be 70 degrees of flexion with 35 degrees of supination. We should have a firm end feel for the proximal radial ulnar joint, and pronation and supination loss are going to be equal for our capsular pattern, both at the proximal and distal end. We have a closed pack position for our distal radial ulnar joint at 5 degrees of supination, so we should see both of those bones both of those joints in the greatest bony approximation at 5 degrees of supination at the proximal and distal joints. For our loose pack position for our distal radial ulnar joint, we need 10 degrees of supination. Again, this should be a firm end feel, and we have equal loss of pronation and supination. Looking at our arthrokinematics, our humeral ulnar and our humeral radial joint are going to have our roll and glide, mostly a glide. So when we think about our roll and glide during open chain motions, we have our concave surface moving on our convex. And so that means we should have our roll and glide happening in the same direction. So for elbow flexion, we have an anterior roll and glide, and for elbow extension, we have a posterior roll and glide in the open chain. For closed chain, then we're going to have our our convex surface moving on our concave, and so our roll and glide are going to happen in the opposite directions. So for elbow flexion, we get an anterior roll of the humerus with a posterior glide, and for elbow extension, we get a posterior roll of the humerus with an anterior glide. Remembering that the humeral radial joint also has an articulation of pronation and supination because the radius is the portion that moves during pronation and supination. So we see a spin that happens between the head of the head of the radius and the capitulum when we perform pronation and supination at our humeral radial joint. The proximal radial ulnar joint is going to have the radius spin on the ulna, and the distal radial joint has the radius roll and glide over the ulna. We're likely not going to worry much about pronation, supination, arthrokinematics, but when we get into joint mobilizations in clinical procedures, we may discuss those movements. Here's just a visual of our arthrokinematics. So we see our concave surfaces of our radius and our ulna. Anterior motion, like elbow flexion, causes anterior roll and glide of the concave surface on the convex surface during open chain motions, and then posterior motion causes posterior roll and glide of the concave surface on the convex surface during closed chain motions. I'm sorry, not during closed chain motions, during elbow extension, I apologize. During closed chain motions, the convex humerus rolls and glides in the opposite direction on the concave ulna. So we get anterior roll, posterior glide with elbow flexion, posterior roll with anterior glide with elbow extension in closed chain when we are moving the convex humerus on the concave ulna and radius. Looking at our question of what arthrokinematic motion is happening at the elbow as a patient unweights themselves in a wheelchair. Well, if we start in a flexed elbow position to get our hands on the armrests and unweight, we're pushing into elbow extension. So we're seeing a posterior roll and an anterior glide of the humerus on the ulna. For pronation and supination, we see spin happening at our proximal radial ulnar joint and the roll and glide happening at the distal radial ulnar joint. The radius must rotate around a fixed ulna for pronation and supination to occur. The ulna has to stay still, and the muscles, therefore, that create pronation and supination have to attach to the radius, since the radius is the bone that's moving. Taking a look at our bony landmarks of the distal humerus, so we'll start at the bottom here. We've got our trochlea that articulates with the ulna on the medial side of the humerus. The capitulum articulates with the radius on the lateral side of the humerus. Our medial epicondyle is going to be palpated just above our elbow articulation on the medial aspect, and that is going to be the attachment for pronator teres. Our lateral epicondyle is going to be about the same level on the lateral aspect of the arm. That's going to be our attachment for supinator. And then our lateral supracondylar ridge, which is that rim running up from the lateral epicondyle, is going to be our attachment for brachioradialis. Looking at our bony landmarks of the ulna, we should be pretty familiar with our olecranon process, as well as our ulnar styloid process is going to be on the opposite side of our radial styloid process. The olecranon process is our attachment site for the triceps. Our trochlear notch is on the anterior aspect of the ulna that articulates with the trochlea of the humerus, and the radial notch articulates with the head of the radius for our proximal radial ulnar joint. And this is just another picture of the radius and ulna together. I think we've kind of covered the bony landmarks on these. The elbow joint capsule and ligaments tend to be pretty friendly. We have our joint capsule that surrounds our articulation with our radius and ulna and the humerus. And then on each side of our elbow joint, we have collateral ligaments. So our lateral collateral ligament is going to be on the lateral aspect, and our medial collateral ligament is going to be on the medial aspect. And then we also have an annular ligament that wraps around the radial head. And the purpose of the annular ligament is to keep contact with the ulna and strengthen the anterior capsule of the joint. But its main job is keeping the radial head in appropriate position with the radial notch of the ulna so that we have appropriate articulation for pronation and supination. Our interosseous membrane is a span of fibrotic tissue that helps to connect the radius and ulna and maintain the relative positions of them in relation to one another. It also provides area for muscle attachments and transmits force through the hand to the humerus so that it's not being transmitted up either one of those bones individually, and helps to reduce trauma to the radius and ulna because of that dispersion of force. Because of the shape of our body and the width of our pelvis, our bodies are designed with what we call a carrying angle. So our arms aren't completely straight to where they run directly down our body, but instead they cut out to the side a little bit to help give us clearance for arm swing. And so this carrying angle is a cubitus valgus, to where the distal segment of the joint points away from the body. And we'll talk about valgus and varus more when we get into the lower extremities. But the angle is formed by the arm and the forearm when they're in the anatomical position. And so to determine what the carrying angle is we would draw a line parallel to the humerus, down extending below the elbow, and then a line parallel to the forearm, and we see what the angle of their intersection is. The angle is formed by the intersection of the lines, and the medial aspect of the elbow is longer, and that's part of what causes this angle. There's anatomical purpose, but the anatomical cause is going to be the medial aspect of the elbow being longer. The carrying angle is 10 to 15 degrees in females and 5 degrees in males, and again, this is because females tend to have a wider pelvis than males, and so anatomically they need greater clearance for arm swing. The radial nerve is one of the branches of our brachial plexus. It comes from nerve roots C5, C6, C7, C8, and T1, and it's going to run the posterior aspect of the upper extremity. So it innervates the triceps, brachioradialis, anconeus, and supinator muscles of the elbow and forearm, and then it innervates the extensor muscles of the wrist and the posterior surface of the arm, forearm, and hand. So if we look down the list at the muscles listed there, we see extensor digitorum, extensor digiti minimi, extensor carpi ulnaris, extensor pollicis longus and brevis, extensor indicis, and abductor pollicis longus. Those are all going to be our wrist and hand muscles that cross the wrist, that are also innervated by the radial nerve. And so if we can remember that the radial nerve innervates the posterior aspect of the arm, then it makes sense why the extensor muscles would be innervated by the radial nerve. The median nerve is another branch of our brachial plexus. It comes from nerve roots C6, C7, C8, and T1. For the elbow, it's going to innervate pronator teres and pronator quadratus, but we'll also pay attention for the wrist and hand, how it innervates the lateral aspect of the forearm and hand. Musculocutaneous nerve is another branch of our brachial plexus. It comes from nerve roots C5, C6, and C7 to innervate brachialis and biceps brachii in the elbow and forearm. And remember, from the shoulder, we talked about how it also innervates coracobrachialis. You can take a look at table 14.4 in your textbook for this, but this is just covering the movements of the elbow and forearm and the muscles responsible for those movements. So elbow flexion is going to be caused by our biceps, our brachialis, and our brachioradialis. Elbow extension is going to be caused by the triceps and the anconeus. Forearm pronation is going to be caused by pronator teres and pronator quadratus. And forearm supination is going to be caused by the biceps and our supinator muscle. So let's dive into those muscles. The first one we'll talk about here is brachialis, and this is just deep to the biceps muscle, and it's the first muscle that's recruited when elbow flexion is required. So when we first go to initiate elbow flexion, it's actually our brachialis that activates first. It originates on the anterior surface of the distal half of the humerus to insert on the ulnar tuberosity and coronoid process of the elbow. It causes elbow flexion and is innervated by the musculocutaneous nerve. Brachialis is the primary elbow flexor when the forearm is in a neutral position. Our biceps brachii muscle sits just superficial to our brachialis, and it also causes elbow flexion, but remember the long head of the biceps crosses the shoulder to contribute to shoulder flexion as well. It activates when the force required for elbow flexion is greater than what the brachialis can create, and more force generation is required, and that's when we get biceps activation. We have greatest strength of our biceps in the forearm supinated position because of it also serving as a supinator muscle. So the biceps originates, the long head comes from the supraglenoid tubercle of the scapula, and the short head comes from the coracoid process of the scapula. They insert on the radial tuberosity of the radius. Their actions are shoulder flexion, elbow flexion, and forearm supination, and are innervated by the musculocutaneous nerve. The brachioradialis muscle originates from the lateral supracondylar ridge of the humerus to insert on the distal lateral aspect of the radius proximal to the styloid process of the radius. So if you guys remember from our reflexes, we palpated proximal to the styloid process to find the tendon, or the radial styloid process to find the tendon for brachioradialis to trigger that reflex. Brachioradialis causes elbow flexion and forearm supination and pronation. So whichever position the forearm is in, if it is in a pronated position and brachioradialis is activated, it's going to cause supination back to neutral. And if the forearm is in a supinated position, it's going to cause pronation back to neutral. So brachioradialis attaches to cause a neutral forearm position, and it is innervated by the radial nerve. And I bolded radialis in brachioradialis because it's our elbow flexor that is innervated by the radial nerve, not the musculocutaneous nerve, and so that can help you keep those innervations clear. Flipping around to the posterior aspect of the arm, we have our triceps brachii muscle. This originates with the long head coming from the infraglenoid tubercle of the scapula. The lateral head comes from the inferior to the greater tubercle on the posterior humerus, and the medial head originates from the posterior surface of the humerus. They all come together to insert on the olecranon process of the ulna. Remember, because the long head of the triceps crosses the shoulder, it contributes to shoulder extension, but it is also the primary mover for elbow extension. It's on the posterior aspect of the arm, so it is innervated by the radial nerve. Anconeus is this small little muscle that most of the time we don't think about. The primary role of anconeus is to help keep the elbow joint capsule from getting impinged, but it does also contribute to elbow extension, and so we learn about it from an anatomical perspective. It originates from the lateral epicondyle of the humerus, and it inserts on the lateral and inferior to the triceps on the olecranon process, and some fibers attached to the annular ligament. It creates elbow extension. It also retracts the joint capsule from impingement during elbow extension, and because it is on the posterior aspect of the arm, it is innervated by the radial nerve. Pronator teres and pronator quadratus are very nicely named because they have their action in the name, and so it's easier to keep those muscles straight. Pronator teres originates on the medial epicondyle of the humerus and the coronoid process of the ulna to insert on the lateral aspect of the radius at its midpoint. It causes forearm pronation and can also contribute to elbow flexion and is innervated by the median nerve. Pronator quadratus originates on the anterior distal fourth of the ulna to insert on the anterior distal fourth of the radius. It causes forearm pronation and also helps to provide stabilization to the distal radial ulnar joint, and our pronator muscles are innervated both by our median nerve. Supinator is another muscle that is nicely named because it tells us its action within the muscle name. So supinator originates on the lateral epicondyle of the humerus adjacent to the ulna. It inserts on the anterior surface of the proximal radius. Its action is forearm supination, and it contributes slightly to elbow flexion, and it is innervated by the radial nerve. So if we take a look at our anterior elbow muscles, we have our more proximal muscles of our biceps and our brachialis innervated by our musculocutaneous nerve. Then our brachioradialis is going to be innervated by the radial nerve because it has radial in the name. And then our pronator muscles are going to be innervated by our median nerve, so pronator teres and pronator quadratus. Our posterior elbow muscles are all going to be innervated by the radial nerve because the radial nerve runs the posterior aspect of our upper extremity. So we have our triceps, our anconeus, and our brachioradialis here. Our supinator is also innervated by the radial nerve because if you look at this hand, it is showing you the posterior aspect of the forearm if we're thinking about it from anatomical position. So our supinator runs in the posterior part of our forearm to be innervated by the radial nerve. Looking at the role of the pronator during elbow flexion, so pronator teres and pronator quadratus are going to oppose the supination action of our biceps. And when we need a forceful quick force, we activate our biceps for elbow flexion. And so we're going to get elbow flexion and supination of the forearm. So when we need forceful elbow flexion, we need our pronator teres and our pronator quadratus to shut off so that we don't have any resistance to that supination motion so that we get full activation of our biceps. Common pathologies of the elbow are going to include medial and lateral epicondylitis. Lateral epicondylitis is going to be more commonly referred to as tennis elbow, and this is inflammation of the common extensor tendon on the lateral epicondyle of the humerus, and we get inflammation of that resulting in the itis portion of that name. Extensor carpi radialis brevis is most commonly implicated in lateral epicondylitis, but it can be any of the wrist extensors that have that common origin on the lateral epicondyle. And this is an overuse syndrome that results from excessive wrist extension motions. Medial epicondylitis is going to be more commonly known as golfer's elbow or little league elbow, and this is inflammation of the common flexor tendon on the medial epicondyle. So wrist flexion motions are going to irritate the medial epicondylitis, and again, this is an overuse syndrome. We have pooled elbow, which is also known as nursemaid's elbow, and this happens to children under about 5 years of age, usually when someone's jerked the child up using a grip on the forearm and the radial head slips out of the annular ligament. So we have subluxation of the radial head that occurs when there's an annular ligament sprain and the radial head moves out of there. Elbow dislocation is going to happen if the sprain is severe enough to rupture of the annular ligament. With a pulled elbow, we have subluxation when there is an annular ligament sprain. We have a full dislocation when there's a rupture of the annular ligament. When we're looking at elbow dislocation, we're looking at typically the articulation of the ulna with the humerus, or the ulna slides posterior to the distal end of the humerus, and this requires a high force being applied to a slightly flexed elbow that then jars the ulna backwards and dislocates the elbow. Fractures that we can see through the elbow and forearm. Forearm fractures are most common to happen in the elderly as a result of osteoporotic changes and an increased fall risk. We can also see supracondylar fractures that happen as a result of a fall on an outstretched arm, where the fracture is just proximal to the condyles. When there's displacement that accompanies a supracondylar fracture, we can see damage to the nerves and blood vessels, so that can cause numbness, tingling, and circulation deficits through the remainder of the upper extremity. Ulnar nerve compression is also common to happen at the elbow or going through the muscles of the forearm. The ulnar nerve spans the elbow on the posterior and medial aspect between the olecranon process and the medial epicondyle. I believe you guys palpated that and felt how weird it felt. But when we get irritation or compression of that nerve as it travels through the elbow space, we can get the numbness and tingling sensations through the ulnar distribution of the forearm and hand. And radial nerve injury, we've talked a couple of ways about how this can happen, but with how the radial nerve travels through the radial groove in the posterior aspect of the humerus, fracture of the humerus, or pressure from a cast that is too tight that compresses the radial nerve can cause a radial nerve injury. Moving on to Chapter 15, the wrist joint. So the wrist joint is the articulation between the radius and the proximal row of carpal bones. There's a disc between the ulna and the proximal row of carpal bones that prevents the ulna directly articulating with the carpals. And so we primarily look at the articulation of the radius with the carpals. The midcarpal joint is between the proximal and distal row of the carpals. The midcarpal joint is considered part of the wrist because it contributes to the amount of range of motion that we have. The intercarpal joints are the joints between the adjacent carpal bones. Muscles of the wrist span the carpal bones to insert on the metacarpals, and this is why we look at the midcarpal bone as being midcarpal joint as being part of the wrist joint. So if we look at our joints of the wrist, most proximally we have our radiocarpal joint. Remember, the ulna has a disc, so we don't have an ulnar carpal joint. There's just the radiocarpal joint. Then between our proximal and distal row of carpals, we have our midcarpal joint. And then between our distal row of carpals and our metacarpals, we have our carpometacarpal joint. So the long bones in our hands after our carpals are our metacarpals, and so articulation between our carpals and our metacarpals is our carpometacarpal joint. So the wrist is a biaxial joint, meaning we have movement in two planes of motion. So we have flexion and extension that happen in a sagittal plane about a frontal axis. We have 0 to 80 degrees of flexion and 0 to 70 degrees of extension. We have more flexion than extension because the posterior radius extends more distally than the anterior radius, so we have more freedom of movement of the carpals in the anterior direction for wrist flexion than we do for wrist extension. For ulnar and radial deviation, those happen in a frontal plane about a sagittal axis. We have 0 to 30 degrees of ulnar deviation and 0 to 20 degrees of radial deviation. Again, we have more ulnar deviation than radial deviation because the radius extends more distally than the ulna, and so we get more obstruction to movement on moving into radial deviation than we do ulnar deviation. So again, a joint where your textbook is going to define hyperextension as what we will clinically define as extension. When we talk about the wrist moving from a neutral position, moving forward in the direction of the palm is wrist flexion, moving backwards is going to be wrist extension. And then ulnar deviation is the sideways movement where the hand moves closer to the ulna. Radial deviation is the sideways movement where the thumb moves closer to the radius. Circumduction of the wrist combines all four movements. For arthrokinematics of the wrist, we have the proximal surface of the wrist joint, which is going to be the radius, and it is concave. The distal surface of the wrist joint is going to be our proximal row of carpals, and that is convex. Then we have our midcarpal joint that has the proximal surface is concave and the distal surface is convex. When we look at arthrokinematics of the wrist, however, we're typically looking at the carpals moving on the radius. So we have convex carpals moving on a concave radius for open chain motions. Arthrokinematic motions of the wrist. So this picture only shows for radial and ulnar deviation because of the orientation, but I think it's an easier picture to understand, so we're going to talk about all motions in the arthrokinematics here. But if we follow the red arrow, we can see the motions for ulnar deviation. And so we know that the hand is going to move medially towards the ulna for ulnar deviation. And so we get a medial roll and therefore a lateral glide because our convex carpals are moving on our concave radius. For radial deviation, we're going to get a lateral roll with a medial glide because our convex carpals are rolling laterally towards our radius but have to glide medially to stay in place. For wrist flexion, we're going to get an anterior roll with a posterior glide of our carpals. For wrist extension, we're going to get a posterior roll with an anterior glide of our carpals. This slide just spells all of that out. Again, flexion, carpal bones roll anteriorly, glide posteriorly. Extension, carpal bones roll posteriorly and glide anteriorly. Radial deviation, carpal bones roll laterally and glide medially. Ulnar deviation, the carpal bones roll medially and glide laterally. Looking at the characteristics of the wrist joint, our closed pack position, or our position with our closest bony approximation, is going to be full extension with radial deviation. And again, I encourage you to try that position with your wrists and you can feel how tight packed the joint feels. Our loose pack position is going to be a neutral wrist with no flexion or extension, just a neutral position. The end feel for wrist in motions in all directions is going to be firm, though you will see some contradiction in different textbooks that talk about the end feel for radial deviation as being hard because of the extension of the radius distally, bumping into the carpal bones. And so literature is going to have some debate, but for this course and most of your clinical purposes, you're going to feel a firm end feel with all wrist motions. And the capsular pattern is going to demonstrate loss of motion that's equal in all directions. Our bones of the wrist, we have our radius and our ulna, and we can see the disc that covers the ulna and it attaches to the radius. So that whole area is considered part of the radiocarpal joint. There's no articulation with the ulna for the wrist. Then we have our proximal row of carpals. We've got our scaphoid, our lunate, our triquetrum, and our pisiform. And then our distal row of carpals is going to make up our trapezium, trapezoid, capitate, and hamate. You can utilize whatever mnemonic that you want, but I think the most common one that you'll find online is some lovers try positions that they can't handle, and that's going to line up for each row of our carpals. We can see our radial collateral ligament appropriately placed on the radial side of the wrist, and our ulnar collateral ligament appropriately placed on the ulnar side of our wrist. The wrist is made up of synovial joints, with the radiocarpal joint being a biaxial condyloid joint, so it has 2 degrees of freedom, and the intracarpal joint is non-axial. They are plane joints, and the motion is arthrokinematic glide. So remember, when we talk about our rolls and glides, we're really talking about the movement of the proximal row of carpals on the radius. A special structure of our wrist that we're all typically pretty familiar with is going to be the carpal tunnel. The carpal bones form a medial and lateral arch with a palmar concavity, so it means it caves in towards the back side of the hand so that we have this divot within our palm, and that's important for grasping. That's part of why the carpal tunnel exists and those arches of our hand exist, so that we can grasp and hold things. This arch is connected by the palmar and transverse carpal ligaments that form a tunnel through which the external finger flexor tendons and the median nerve pass. And so this creates an enclosed space where if we have any kind of inflammation or tension within that enclosed space, we end up seeing compression of the median nerve. And that is why people who have repeated flexion of the fingers in a wrist extended position, such as with typing, are more susceptible to developing carpal tunnel syndrome. Looking at just a visual of that, so we can see the median nerve located in here with the tendons of our flexor pollicis longus, our tendons of our flexor digitorum profundus, and the tendons of our flexor digitorum superficialis. So all of those tendons are running within the carpal tunnel, compressing the median nerve as it passes through when we have inflammation or irritation to those tendons. The palmar radiocarpal ligaments, or just singular ligament, it's one ligament with multiple parts, and so you'll see it called ligaments plural in some textbooks and ligament singular in other textbooks. It attaches at the distal radius and then runs to the proximal carpal bones and has attachment on all of the carpal bones in the proximal row, and it helps to reinforce the palmar aspect of the joint capsule and also serves to limit wrist extension. The dorsal radiocarpal ligament is going to do the same thing, or attach rather, to the same places as the palmar, but on the opposite side. So this is going to be the posterior aspect of the wrist. It attaches to the distal radius and the proximal carpals, except for the pisiform, because the pisiform is more anteriorly located. It helps to reinforce the posterior aspect of the joint capsule and limits wrist flexion. The palmar aponeurosis is a broad span of connective tissue on the anterior aspect of the hand, and it serves to cover the tendons of the extrinsic hand muscles to provide protection, and is also the distal attachment of palmaris longus. So just for clarification there, the extrinsic hand muscles are going to be muscles that cross the wrist. We'll talk about intrinsic versus extrinsic hand muscles when we get into the hand chapter. But if the muscle crosses the wrist, it's going to be an extrinsic hand muscle. And this is what the palmar aponeurosis serves to protect, and then also, again, the attachment site for palmaris longus so that we can get motion of the hand. Because of the shape of the forearm and the way that it tapers down to the wrist and then opens back up into the hand, we have to have special connective tissue that holds our tendons in place. And so in the wrist, we have our flexor and our extensor retinaculum. And this is a band of connective tissue on the anterior aspect for the flexor retinaculum and on the posterior aspect for the extensor retinaculum that covers the extrinsic hand muscles running into the hand or the tendons of them to help hold them in place. And they serve to hold the flexor and extensor tendons close to the wrist and prevent bowstringing of the tendons during wrist movement. So if you think of a bow like a bow and arrow, we've got the string that we pull back on, and that's what our tendons would look like as we flex or extend the wrist if we didn't have the retinaculum in place to hold those tendons where they need to be. Let's talk about innervations. So our radial nerve we know comes from our brachial plexus, nerve roots C5 through T1, and runs the posterior aspect of the arm. So it innervates extensor muscles, and this is true for the wrist as well. So running down into the forearm, and to cross the wrist, we innervate the extensor carpi radialis longus, extensor carpi radialis brevis, and extensor carpi ulnaris. The median nerve, another branch of our brachial plexus, coming from nerve roots C6, C7, C8, and T1, innervates the anterior lateral muscles of the wrist, including flexor carpi radialis and palmaris longus. The ulnar nerve, another branch of our brachial plexus coming from nerve roots C8 through T1, innervates the muscles of the anteromedial forearm, including flexor carpi ulnaris. Muscles of the wrist have common origins for flexors and extensors, and we talked about these a little bit when we talked about medial and lateral epicondylitis. But our common flexor tendon is going to originate on the medial epicondyle of the humerus, and our common extensor tendon is going to originate on the lateral epicondyle of the humerus. Only two muscles attach to structures of the wrist, and that's going to be our flexor carpi ulnaris and our palmaris longus. Most of the muscles of the wrist have a vertical line of pull, and that's part of why we need the retinaculum to hold them in place so that we don't have a bowstringing effect. There are no individual muscles that produce radial or ulnar deviation. We have to have a combination of muscle activation to achieve either one of those. So for radial deviation, I need activation of both my flexor carpi radialis and my extensor carpi radialis. For ulnar deviation, I need activation of my flexor carpi ulnaris and my extensor carpi ulnaris. But if I activate either one of those individually, I'm going to get deviation into ulnar deviation and flexion, or ulnar deviation and extension. And so I need both of them acting together to get straight plane radial and ulnar deviation. Muscles that cross both the elbow and the wrist have to be stretched at both. So the muscles originate at these common flexor and common extensor tendons really close to the elbow. So they don't play a huge role in causing elbow flexion or elbow extension. But it's important to understand when we're looking at muscle length, especially if we're trying to stretch those muscles. So if I'm trying to stretch my wrist flexors, I get a better stretch when I hold wrist flexion with an extended elbow than I do if I have my elbow flexed at my side. I would encourage all of you to take a moment to try to stretch your wrist flexors and your wrist extensors, both with a flexed elbow and a straight elbow, and see if you can note the difference in the degree of stretch that you feel. We talked about this with radial deviation and ulnar deviation. We need synergistic muscle activation in order to have it. Otherwise, we can't achieve straight plane motion. So radial deviation, again, is going to be caused by flexor carpi radialis and extensor carpi radialis longus. And again, synergistic movements, meaning that those muscles have to work together to produce the motion. Ulnar deviation is going to be flexor carpi ulnaris and extensor carpi ulnaris. Again, synergistic muscle activation. With ulnar deviation, it's important to think about our function. And functionally, when we hold things, gravity is pulling us into ulnar deviation. And so we tend to see an ulnar drift with aging. We tend to see weaker muscles in our contributors to ulnar deviation because, again, gravity is pulling us into that position more often. And so we have to think about the functional implications of ulnar deviation and why we require more radial deviation to do things with the things we hold in our hands. Taking a look at each one of these muscles individually, we'll start with flexor carpi ulnaris. So it originates on the medial epicondyle of the humerus via that common flexor tendon. Remember, it has flexor in the name. Carpi, the carpal is where it attaches to. Ulnaris, it's on the ulnar side of the forearm. So I think these muscles are really nicely named because they tell you a lot about where they are. It inserts on the pisiform and the base of the fifth metacarpal. The action is combined wrist flexion and ulnar deviation. So if we get activation of just that muscle, we're going to have ulnar deviation with wrist flexion. And it's innervated by the ulnar nerve. Flexor carpi radialis, again, is a flexor muscle, so it's going to have its origin at that common flexor tendon, and it inserts on the base of the second and third metacarpals. Flexor carpi radialis means it runs on the more of the radial side of the hand. It causes the combined motions of wrist flexion and radial deviation and is innervated by the median nerve. Palmaris longus is a superficial muscle of the wrist that not everybody has. If you go ahead and flex your wrist while bringing your thumb and pinky together, the tendon that pops out at your wrist is your palmaris longus. You can go ahead and check both sides and see if you have one on both sides. About 30% of the population does not have a palmaris longus in both arms. It originates from the medial epicondyle of the humerus via the common flexor tendon to insert on the palmar aponeurosis. Remember, that's the connective tissue that covers the extrinsic wrist flexor muscles, or tendons of the extrinsic wrist flexor muscles. It serves to cause wrist flexion and is innervated by the median nerve. Extensor carpi radialis longus. So extensor, it's going to extend the wrist. Carpi, it attaches to the carpals. Radialis, it runs on the radial aspect of the forearm. Longus, it is longer than its partner, brevis. Brevis is going to mean short, longus is going to mean long. It is the only extensor muscle that does not have its origin at the lateral epicondyle of the humerus. It originates on the lateral supracondylar ridge of the humerus, so it originates a little bit higher than that common extensor origin. It inserts on the base of the second metacarpal to cause combined wrist extension and radial deviation, and it is innervated by the radial nerve as an extensor muscle on the posterior aspect of the arm. Comparing that to extensor carpi radialis brevis, remember brevis means short. It's shorter because it originates more distally. This one does come from the lateral epicondyle of the humerus via the common extensor tendon. Remember, that's going to be a little bit more distal to the supracondylar ridge, and why this muscle is shorter. It inserts on the base of the third metacarpal to cause wrist extension. It has very limited contribution to radial deviation, and so that is an important difference to note between longus and brevis. It is on the posterior aspect of the arm, though, so it is innervated by the radial nerve. Extensor carpi ulnaris is an extensor muscle. It attaches to the carpals, runs along the ulnar aspect of the forearm, originating from the lateral epicondyle of the humerus via the common extensor tendon to insert on the base of the fifth metacarpal. It serves to create wrist extension and ulnar deviation and is a posterior arm muscle. It is innervated by the radial nerve. Our anterior wrist muscles are going to include flexor carpi radialis, palmaris longus, and flexor carpi ulnaris. Flexor carpi radialis and palmaris longus are both going to be innervated by the median nerve, but flexor carpi ulnaris is innervated by the ulnar nerve. Looking at the posterior aspect of the forearm for the wrist muscles, all of them are going to be innervated by the radial nerve because the radial nerve innervates all of the posterior upper extremity. So we have extensor carpi ulnaris and then extensor carpi radialis longus and brevis. This is just a summary of table 15.4 or -4 in your textbook, looking at motions of the wrist and the muscles that contribute to those movements. So for wrist flexion, we have flexor carpi radialis, flexor carpi ulnaris, and palmaris longus. Wrist extension has extensor carpi radialis longus and brevis, and extensor carpi ulnaris. Radial deviation is extensor carpi radialis longus and flexor carpi radialis, and ulnar deviation is extensor carpi ulnaris and flexor carpi ulnaris. I don't remember if I put a before class slide after these pathologies, so please remember before class to review the anatomy of the elbow, forearm, and wrist in preparation for taking range of motion and manual muscle testing measurements on those in lab. You'll also want to write down any questions that you have over this lecture so that we can discuss them prior to beginning the lab activity and prepare lab-appropriate clothes for manual muscle testing and range of motion assessment of the elbow, forearm, and wrist for class. We'll wrap up with our common pathologies of the wrist, and fractures are going to be one of the most common injuries that we see happen to the forearm and carpal bones. Obviously, we can't fracture a joint, but we can fracture the bones that make up that joint. Different types of fractures that we can see happen at the wrist is a Colles fracture, which is a transverse fracture of the distal radius that causes a posterior displacement of the distal fragment, versus a Smith's fracture, which is also a transverse fracture of the distal radius with an anterior displacement of the distal fragment. So if we're looking at the distal fragment, we're talking about the distal end of the radius pushing posterior in a Colles fracture, and that's going to result in this deformed wrist flexion position, or anterior in a Smith's fracture that's going to result in this deformed wrist extension position. We have green stick fractures, and if we'll remember from the skeletal system chapter, those are going to be where we see splaying and breaking on one end and bending on the other side, and that's because they are fractures that happen in children. They're incomplete fractures, and they typically happen more proximally when we're talking about fractures of the radius or ulna. Scaphoid fracture is another common pathology that we can see that has concerns because of the vascular involvement, and scaphoid fractures can result in avascular necrosis of the scaphoid because of disruption of the blood flow to the region. Ganglion cysts are fluid-filled cysts that form a bump on the dorsal surface of the wrist. They may or may not cause symptoms, and so they typically only require treatment if it's painful or limits function. Wrist sprains are pretty common. Again, falls on outstretched hands are going to be one of our most common causes of wrist sprains. And this is where the ligaments stretch and become inflamed. The most commonly sprained ligament of the wrist is going to be the scapholunate ligament. And carpal tunnel syndrome, we talked about a little bit when we reviewed what the carpal tunnel is, but that's where we see compression of the median nerve as it passes through that carpal tunnel. And symptoms include pain and tingling, which worsen over time in the median nerve distribution of the hand. And we'll talk about that more when we go through the hand lecture.